I think I've just explained that actually. Sample of whole blood is taken from the patient. That's a 0.36 mils to be exact. It's placed in a cup. The pin is lowered into the blood, as we were saying before. The pin, that's the pin, is lowered into the blood. The cup is rotated, as we were saying before. Whereas the lab sample is not whole blood because they've spun it around. And yeah, that's the difference. It's been in the bottle for a while and it's spun in the centrifuge. Okay, clot formation. A normal clot is fast forming and fast strengthening, and it's got a very characteristic pattern, very characteristic curve, which I'll show you in a minute, and which, you know, within the normal parameters, which we'll talk about, as an easily recognizable pattern. So once you have been using this machine a couple of times, you can easily tell which one is a normal pattern and which one is deranged. It's just a matter of pattern recognition. It's like ECGs. A normal clot, you can see it will stretch. It won't be as sturdy as a strong clot. It will have a narrow pattern, and you can easily identify that, you know. So there are 5 parameters of TEG tracing. And what are they? There's what they call the R parameter, which means a period of time from initiation to clot formation. So as soon as the pin goes in to when the clot starts to form, that's called the R period. It's like on the ECG, you know, you got the waves and stuff. So here you've got these. You've got the K component. And this measures the time from the beginning of the clot formation until the time the amplitude of the TEG reaches 20 millimeters. Now here I've got a couple of diagrams. Let me see if I can zoom in on them, and you guys can get a closer look. Oh, I've gone in the wrong place. Trying to zoom in on these. Zoom. Oh no. Alright, yeah. There we go. So this is actually, this is what the TEG graphs look like. As you can see, what we're talking about here, the R, the K, we're gonna have the next one there. MA and the angle. So the R period is from here to here. So this is the period we're talking about when the clot starts forming, right? And the K period is from here until, I'll tell you in a minute because I don't know it off by heart. And then the angle is over here, which we're going to talk about. And the MA is from here to there. And these are the parameters. So once you understand, you know, the correct, what the parameters are supposed to be, you can see what yours are and you can compare, just like on a blood gas. And this is what the normal sort of curve looks like. It's a very sharp incline there as the blood starts forming, and this period here shows you know it's nice and strong and stable for a long time, you see. So it clots quickly, goes up, and is stable. Whereas a dodgy one will clot much slower, you know, and it's not stable. It's stable, but it's not even, you know, this has gone up here. It's like strong. It's gone up there. That's like an indicator of the strength. And that's stability. This one's stable-ish, you know, even after a bit starts going down, but it's not even that strong because the incline here is not as much as the normal one. So you can tell that this is somebody not clotting very well. This person is going to bleed, you know, whereas that one is normal, you know. So that's how this works. So we go to the next one. The alpha angle, that's the angle we're talking about there before, and this represents the acceleration of fibrin buildup and cross linkage. Okay, acceleration, that's angle there. It represents the acceleration of fibrin buildup and cross-linking. The angle right there. MA, that's the next parameter, maximum amplitude. That shows you the strength of the clot. And it's dependent on the number and function of the platelets. Now that's MA, right there. From there to there. It tells you the strength of the clots. This is what I was trying to say before. It's rising and stable for a long period there. So it's a strong clot. This one is only rising a little bit, and it's not even stable. It's coming down, so it's not that good. So the number, probably, of this person's platelets is probably deranged, either deranged or not functioning properly. Because, like I was saying before, you can have a patient with few platelets are normal, but it's not bleeding. Why? Because they're functioning properly. So the function of the platelets is also important. This is what we're saying. And the interaction with fibrin is also indicated. MA60 is pretty much the same thing, but it gives you, the rate of the strength of the clot over 60 minutes. Determines the stability of the clot. Is that patient likely gonna be if the bleeding stops, if it's corrected, are they likely going to not stay not bleed for the rest of the night? If after a while you see that the clots that the patient are producing are sort of diminishing in their stability, then you know that probably later on they will bleed. They're not bleeding now, but they might bleed. So you need to start acting. So what does this mean for us? What does it mean for us nurses in ICU? Well, it's a more accurate reflection of the patient's coagulation. They're already using it at Glenfield. The anesthetist over there was very pleased with it. He says it allows for better decision making, appropriate actions to be taken, a reduction in, do they really need that? Conversations with the path lab. Because the path lab, it can be quite, I don't know. I won't say anything. Less exposure to foreign blood products and faster results, which leads to hopefully improved patient outcome. We don't have to have patients bleeding unnecessarily. It can help us to act quicker than we would have before. I think if applied properly, it's got the potential for that. It's also got the potential for less wastage of time and resources. Like if we are able to diagnose and take appropriate action sooner than we would have without this machine, then we would reduce the amount of resources that we use, blood resources, money, things like that. Cost implications of this. I forgot to ask how much this thing costs, but it's probably quite expensive. But according to the Health Assessment Technology Report, an NHS document, June 2008, they were saying that in cardiac and liver transplant environments, this machine cut down 400,000 pounds in expenditure in 1 year. A combined amount of 400,000 was saved because they were using this machine in cardiac and liver transplant scenarios. But the downside is that so far there's no other robust data for other surgery at present, and the actual cut down time of intensive care, inpatient stay has not actually been tested that well. But I think it's more to do with I don't know, if used properly. In theory, this would reduce ICU waiting time.